residents of my previous place, AIIMS Medical College. It started with all the residents of that college, and subsequently residents from other medical colleges and other parts of this country. And now it has grown into faculties from many countries as well as from across the country. They are just joining in this surgical academia. So slowly it is picking up. So in fact, this adversity has brought in this opportunity, and we started off initially as a solo venture. I was doing just weekly webinar with all these attendees. Subsequently, I thought of chipping in all my friends and colleagues across the country. And now it's going on every week, Tuesday, 7:30 p.m. So in that process, today we are into another session of webinar where we have got an excellent speaker, Dr. G.V. Rao. In fact, G.V. doesn't need any introduction to the surgical audience in this country. He's the director and chief of surgical gastroenterology and minimal invasive surgery in Asian Institute of Gastroenterology in Hyderabad, and a very good friend of mine. And he's a soft-spoken, brilliant surgeon. And the fantastic facet of GV is an excellent surgeon and a very good endoscopist as well. So in fact, a surgeon doing endoscopy, GV is one of the prominent among them. In fact, in my previous institution, I was also into Ercp. After joining AIIMS, that facet is gone now to medical gastroenterology people. They're all doing it. So anyway, GV I have been associated with him for last quite many years. We are in the Indian Association of Surgical Gastroenterology. We are in the formation of the curriculum for the MCS DNB in several meetings that we are having in AIG in Hyderabad. So many times it was a long association. And today's moderator is Dr. Baiju Sanathipan, a short stature, high power man. Baiju is a senior consultant and head of the Department of GIS, PB, Bariatric and Transplant Service in BR Life Acute Patam Hospital in Trivandrum, Kerala. Baiju is a really short stature but an excellent surgeon and a fantastic human being. Baiju runs a very good educational foundation, Sanathipan Education Foundation. In fact, he also conducts his weekly webinar, and we just have decided not to clash with each other's events. So Baiju does it every Sunday, 8 p.m. and we do it every Tuesday, 7:30 p.m. so that we do not clash with each other, but we make a fantastic combination and we always discuss. And he's an excellent friend and fantastic human being, and a fantastic family man as well with Professor Leroy. And Baiju is a complete man. So the next in card next week, same time, we'll be having another interesting webinar on how magnets can change the scenario in laparoscopic surgery. So in fact, for that, Dr. Guillermo Domínguez he's the head of in Argentina. He's the head of minimal invasive surgery in Fantasio Hospital area. So, and they will be moderated by Gustavo Cavallo. That will be interesting session next week sometime. So without wasting much time, let me hand over the entire session to Baiju Sanathipan. Baiju, please.
Thank you, Manash. Am I audible?
Yeah, you are audible.
Thank you, Manash, for the nice introduction. I am overwhelmed. You all know Dr. G.V. Rao. I don't have to introduce G.V. Rao to this august audience inside the country and outside the country also. He is a fantastic human being. More than that, he is he is one of the directors of Asian Institute of Gastroenterology. You know the connection between the medical gastroenterologist and the surgical gastroenterologist. It is because of that symbiotic relationship between the medical gastroenterologist and surgical gastroenterologist. The AIG has grown to this level that it has become the biggest gastroenterology hospital in the world. So, hats off to you two people, Dr. Nagesh Reddy and Dr. G.V. Rao, for having such an institution. You love to dream about it and materialize it. It's hard work and
I mean, you are absolutely true, Baiju. Once you are into that new AIG setup, you never feel that you are inside India. You will feel as if you are somewhere outside the country. It looks a 7-star hospital. It's a fantastic setup. In fact, the last meeting that GV had of that this surgical gastroenterology MCH DNB curriculum revision, it was fabulous. The setup and the things are so nicely designed. Yes, please continue.
Yeah. Actually, GV has invited me to visit that place. Actually, one day I have visited AIG, the previous AIG 5 times in my
Yeah.
career to learn something. So he has invited me again to visit the new place. We'll be going and seeing what our facilities are there. Actually, I love the endoscopist in GV Rao more than the surgeon, because he is a well accomplished surgeon in laparoscopy, open surgery, and not surgery also. But have you seen him doing ERCPs? Have you seen him doing other endoscopy procedures? It is fabulous. So I love to have him in my platform for an endoscopic teaching session. So probably you'll be agreeing to it. I'm not wasting much of your time. Over to Dr. G.V. Rao for the fantastic presentation.
Thank you. Thank you so much. Actually, today evening I'm with two of my favorite persons. Actually, one on the private sector and one on the public sector, who have done immense work actually in the field of surgical gastroenterology. Dr. Manas actually, who has been doing an extremely good work on the public sector, and he has made a big name, and he has set up a huge institution, and people. I mean, I think, had I had a chance, actually, when I was in the beginning of the career, like something like this, I think, I don't know how it would have been actually. And Baiju, actually, I mean, phenomenal technician, actually. I mean, I love him operate, actually. Baiju has been doing phenomenal work on GI side. Actually, been interacting with him in various side, surgical forum. I would like to have them n number of times at my institute to teach my students, actually, so that they can also learn from them. And this is a fantastic opportunity that is given to me by Manas. Thank you, Manas, so much. Actually, from the bottom of my heart, I'm thanking you for this opportunity that is given. Manas, what I thought I'll talk to you about the overall scenario, because working in a department in a hospital where we have both endoscopy, laparoscopy, open surgery, and interventional radiology, and we have people of equally good caliber in all the specialties. I just thought I'll just run through what happens in my department and also give you the evidence what is happening across the world. So if you see the management in 2020, acute pancreatitis, actually it is one of the most commonest admissions into the intensive care unit and the critical care, and is associated with significant morbidity and mortality. Most of the literature is focused on drainage and debridement techniques and technology, and which have improved the morbidity and mortality to some extent. And there is some amount of disconnect between the critical specialties which are responsible for the continued increase in morbidity and mortality. There is some amount of disconnect between the different specialties that are dealing with this. Fortunately, in my hospital, actually, we seem to work on a common platform, so we seem to be interacting with other critical subspecialties which are involved in the management of acute pancreatitis. Now, before going on to the interventions in acute pancreatitis, I'll just for the benefit of those junior surgeons who have logged in and junior endoscopists who have logged in, just to share 8 fundamental steps which are revised according to the Pancreas acronym. So these are the 8 fundamental steps that you follow in patients with severe acute pancreatitis. P is for perfusion, A is for analgesia, N is for nutrition, C is for clinical assessment, R is for radiology or cross-sectional imaging, E is for ERCP or endoscopic interventions, A for antibiotics, and S for surgery, interventional radiology, or endoscopy. This is a acronym that the Pancreas acronym that is used to show the 8 fundamental steps that we use in severe acute pancreatitis. I'll just run through this. The perfusion goal should be to reach a CVP of 12 to 15 millimeters of mercury and maintaining the urinary output at 0.5 to 1 ml per kg per hour, and the IPPC collapse index of about more than 48%. This is the perfusion goal that we have to achieve. Analgesia is basically multimodal, systemic, combined pharmacological agent, and maybe an epidural block in some of these patients. Nutritionally, enteral feeding in gastric or post-pyloric position, parenteral nutrition works best in difficult cases to achieve the individual total caloric value. As far as possible, we maintain these patients on enteral feeds. Clinically divided as mild, moderate, or severe pancreatitis according to the Atlanta criteria. The CT is done on the 4th day for prognosis or to modify the management of patient with severe acute pancreatitis. Ercp is done in patients with cholangitis, unpredicted clinical course, and ascending jaundice. Antibiotics, only rational indication is in documented acute in pancreatic infection. Surgery, interventional radiology, and endoscopy. The dogma is represented by the 3 Ds, delay, drain, and debride. The preferred method is a minimally invasive step-up approach, which allows for gradually more invasive procedures when the previous treatment fails. So this pancreas acronym that I was talking about is summarized in 5 Ds. So the entire process is to delay as much as possible, drain the infected fluid, debride as much as possible, and if you deviate from any of these norms, obviously it results in increased mortality in these patients with severe acute pancreatitis. So acute pancreatitis is basically interstitial edematous pancreatitis. Less than 4 weeks, we call it as acute peripancreatic fluid collections. More than 4 weeks, we call it as pseudosis. Suppose if it is necrotized acute pancreatitis, less than 4 weeks, it is called as acute necrotic collection. More than 4 weeks, it is called as walled-off necrosis or walled-off pancreatic necrosis. So diagrammatically, cartoon-wise, this is how it looks. Less than 4 weeks, it is pseudosis, and more than 4 weeks, it is pancreatic necrosis, and now it is called as walled-off pancreatic necrosis or walled-off necrosis. Now, this Todd Barron, he is the gentleman, is an endoscopist. Now, he created the term WON, walled-off necrosis. Now, this basically is an endoscopic definition. I'll tell you why. Now, by WON, it means if you're seeing fluid, it means it is a pseudosis. If you're seeing even small amount of debris, it becomes walled-off necrosis. Now, this is basically an endoscopic definition because now we have debris, we have necrosum. That constitutes a walled-off pancreatic necrosis. And as per surgically, if you see, now this is the debris part, this is the necrosum part. Now, in 2020, all the endoscopic interventions are endoscopic ultrasound based, and endoscopic ultrasound is highly sensitive to detect debris. So as surgeons, we used to practice surgery based on CT scan. Now with the advent of endoscopic ultrasound, most of the CT pseudosis become endosono-WONs because even small amount of debris that is detected on the pseudosis, it obviously is categorized as a walled-off necrosis now. So most of the WONs in endotherapy series are CT pseudosis. Actually, I'm making a very provocative statement, but it is true that most of the WONs and endoscopic therapy treatment series that we talk about are all CT pseudosis. So as in today, now are there no non-WONs? You're talking about walled-off necrosis, very good. Does it mean there are no, other than walled-off necrosis, are there any necrosum, what do we call this necrosis that extends into the paracolic gutters, into the pelvis mesentery, or into the mediastinum? This is what as surgeons we encounter day in and day out. Now these, and the question that is repeatedly asked is this terminology pancreatic necrosis absolute today? And we just have to talk about WONs? Absolutely no. Now all these extended collections that we see now are termed as extended walled-off pancreatic necrosis as compared to the simple walled-off pancreatic necrosis that the endoscopists talk about. Now, all the management concepts have evolved from surgery. Surgery has been the gold standard for treatment of pancreatic necrosis across the globe, and all the management principles have evolved from surgery. Be it be endoscopic, be it be radiological principles, all have evolved over surgery. Now, the mortality of infected pancreatic necrosis is about 30%. When you have infected pancreatic necrosis with septic complications, it becomes 80%. And if you have infected pancreatic necrosis with multi-organ failure, and if you continue to treat these patients conservatively, it is 100% mortality. Now, there has been a lot of number of trials which have shown that if you go in and intervene early, the mortality is very, very high. So that's the reason why we delay the intervention as much as possible. And we have beautiful randomized control trial which shows that if you go in early, the mortality is going to be very high. So we have to delay as much as possible before we go in to intervene in any of these walled off pancreatic necrosis. Ideally, it is after 4 weeks, basically because of proper demarcation of pancreatic and peripancreatic necrosis. It decreases the risk of bleeding whenever we do this necrosectomy, and it minimizes the surgical related loss of vital tissues. Now, the therapeutic issue, it means what it involves is drainage of as much of infected fluid and mechanical removal of as much of necrotic tissue as possible. Now, the indications would be obviously.
Can I interrupt for a second? Can I interrupt for a second?
Yes.
The slides are not seen here. I think somebody else has shared his slide.
Okay, can I just
stop?
Dr. Ravi Shankar, I think.
Dr. Shivsankar, please don't present now. Don't press the present now button. Dr. Shivsankar. Dr. Paswan. I think he has pressed the present now button. That's why probably is creating. I am able to see now.
It's okay now?
No, we are not getting the slides.
Okay. Shivsankar.
Dr. Shivashankar, can you please turn off your slide presentation?
I think Shivsankar.
Do you have any option of stopping the slides from the your side?
Shivsankar, please stop.
Yes, sir. Yes.
Yeah, you've done it. Okay, fine. Thank you.
Hello.
Yeah.
Hello.
Dr. Paswan, you just stop present now. Don't press the present now button.
Sir, we can just pin the slides so no one else can.
Okay, we can pin the slide. And the slide is pinned, but still.
Sir, if somebody pin the slide to the main slide, it will show the sir. Even if somebody presents also, this slide will be presented.
Okay.
I think you can end this slide and restart.
Yeah.
We can. I think GV can pin it now.
Yeah. Now it is coming.
Yeah. Yeah, and I have to pin it. Yeah. Fine.
Visible.
Please go ahead. Yeah.
Please,
So,
please don't press on the presentation slide, the slot till the presentation is over.
So the indications for intervention for walled off pancreatic necrosis would be infection, organ failure, intractable pain, patient with gastric outlet obstruction, or a disconnect pancreatic duct. Now, surgery has been the gold standard for management world over. There is no doubt about this. And interventional radiology, the Panther Trial came in 2010. The Dutch trial which came in 2010, and the first ever time that this article came in NEJM. And this change, though it's a very small series, it showed a step-up approach wherein you drain the infected fluid first and then do a minimally invasive necrosectomy. And this paper, which came in NEJM, seems to have changed the entire line of management of walled off pancreatic necrosis. Now, though this is a very small series of patients who are presented, actually very select group of patients that are presented, they showed that the mortality is less when you have this step-up approach, and this seemed to have caught on. And people across the globe started practicing interventional radiology or a step-up approach. And recently, in 2019, they presented their long-term follow-up to show that this is a very favorable procedure which can be practiced so that the morbidity is less in this patient. But surprisingly, as the radiologists were doing this procedure along with the surgeons, endoscopy came in a big way, and they have also shown that endoscopic procedures are becoming more and more popular. And because of the limited evidence that we had on the Panther trial and subsequent follow-up and subsequent literature from across the globe, suddenly they've realized that both endoscopy and surgery in the form of minimally invasive surgery also seem to have equally good results. So this Panther trial, which came in 2010, created endoscopic tension. The endoscopists who started practicing aggressive endoscopy, they started doing very aggressive endoscopic procedures, and this created a tension among endoscopists, thinking that they would lose this area. So they started aggressively practicing this endoscopic therapy. So you can see this umpteen number of centers across the globe started aggressive endotherapy for walled-off pancreatic necrosis. And in 2020, if you see for walled-off pancreatic necrosis, we have interventional radiology, endoscopy, surgery. Surgery could be open, laparoscopy, or retroperitoneoscopy. Now, initially, when endoscopy came in, they used to do this, what is called as direct endoscopic necrosectomy. They used to balloon dilate this tract using a CRE balloon, go into the retroperitoneum, debride as much as possible, and put in stents. Now, there are a lot of data to show that this had good results, but surprisingly, the complication rates were very high. And some of these complications were torrential, like these bleeds coming from these retroperitoneal vessels, or some of them, when the walled-off necrosis was not mature, the stents migrated into the free peritoneal cavity, and these obviously started requiring surgical intervention. So what changed the entire management on the endoscopic side was the introduction of these short biflange self-expanding metallic stents, which are also called as lumen-opposing metallic stents. Three types of stents are available as in today: a Nagy stent, which is derived from our center, the Axios, and the Spaxus stents. Now these stents seem to have changed the entire game and become the game changer, and these lumen-opposing stents are supposed to be superior to the fully covered metallic stent that were used, and also the plastic stent that initially people used to use to drain these fluids. And there is a lot of literature from across the globe, including from our center, which has shown that these walled-off necrosis, which can be treated by these self-expandable lumen-opposing stents, do extremely very well with minimal morbidity and mortality. And there are also, and there are a lot of data which started comparing this endoscopic methods with standard surgical necrosectomy. Mind you, whatever has come in comparison, this is endoscopic transgastric versus surgical necrosectomy that involves not only transgastric, but all types of necrosectomy that we do on surgical side. And obviously they reported increased pancreaticocutaneous fistulas and increased morbidity associated with these procedures. Surgical procedure, basically because they compared endoscopic transgastric versus all surgical necrosectomies. So, and likewise, we had this other trial, which came, the tension trial, which came in, which compared the endoscopic with the surgical step-up approach, and it also was in favor of endoscopic treatment. And with these advances in endoscopy, people thought that time has come wherein all the walled-off pancreatic necrosis can be treated endoscopically. And there are a lot of editorials which are coming in to show that endoscopic drainage might replace surgery. Now, is this true? We'll just see that. Now, these are the equipment that we have on the endoscopic side. We have a rat tooth forceps, we have a nasobiliary drainage, and we have this lumen-opposing stent. We have Roth baskets to extract this necrosum, and sometimes we use hydrogen peroxide to irrigate this. The myth is that the endoscopics believe that because they're creating a hole, the gastric juice gets into the retroperitoneal cavity and it aids in clearance of necrosum. Majority of the time, they just drain the thing endoscopically. We drain the thing, and the amount of necrosectomy is done is very, very minimal. I'll show you that. This is the beautiful paper that is published from our side, which talks about an endoscopic step-up approach using these metallic stents. Mind you, see this paper very, very clearly. This is the paper presented from our side of all the walled-off pancreatic necrosis that are managed endoscopically using this lumen-opposing stent. Now, we had this huge number, okay, of 205 patients which are of walled-off necrosis, which we treated with this lumen-opposing stents. And you can see this, 75% of the patients did not require any necrosectomy. They just put in the stent, let out the fluid, and then patients did well. This is again basically because, as I told you, most of the pseudocysts that we are talking about are become endoscopic wall of necrosis, because even small amount of debris that is seen in the wall of necrosis, it becomes a wall of necrosis. So 75% of the patients did not require any necrosectomy. It is just they put in a stent, patients did well. Now, of the 25% of the patients who did not do well with primary stent, some of them had the stent which was clogged with minimal necrosis, so we declogged the stent and they did very well. Some patients we put a nasocystic catheter irrigated and they did well. And only if you see, only less than 10% of the patients required necrosectomy. So you can see this in most of the endoscopic series. Walled off necrosis means debris, even minimal amount of debris is taken a wall of necrosis. And mind you, necrosectomy is done in very small percentage of patients. Not all patients undergo necrosectomy. And this is what I mean. You put a stent here. Sometimes this necrosis blocks this stent. You remove this, and subsequently the patients do well. Or you can put this nasocystic drain and irrigate the cavity. And very rarely, less than 10% of the patients require this direct necrosectomy, wherein you go inside the retroperitoneum with the endoscope and using this Dormia basket or a Roth basket or a snare, you do the debridement. And this is the final conclusion of our study, which shows that actually majority, you can see that 90% of the patients do very well just putting in the stent. Less than 10% of the patient require some sort of direct endoscopic necrosectomy. Because the endoscopists were not able to do complete necrosectomy, they combined the procedure with the radiologist. So you put in a pigtail catheter or a Ballycott's catheter to drain whatever is not drainable using this self-expandable metallic stents. So they put in a stent to drain whatever is drainable, and whatever is not possible, it is usually dealt with the interventional radiology. And you can see this, and whenever we are not able to do that, the intervention, that is a track that you do. Now you do a sinus tract endoscopy, you do this debridement. So the endoscopists have become aggressive. On one side, trying to do some amount of necrosectomy, and wherever it is not possible to do endoscopically, they started using additional radiological procedure to do this debridement. So now we have this interventional radiology procedure, and we have this endoscopy procedures. Now, do these mean, are the Panther Trial, that the radiology procedure, the penguin tension, the Nagy stent, or the axial stent, does it mean that it's death knell to conventional surgery? Now let us see this. Actually, we are talking about for walled-off pancreatic necrosis in good approximation to the stomach or duodenum. Absolutely, endoscopy may be very good, and if the debris is less, maybe we can do an endoscopic drainage. But for all these, paracolic gutter extension, mediastinal extension, or pelvic mesenteric extension, surgery still remains the gold standard. And as I told you, all the management concepts seem to evolve from surgery. So let us see, in the era of minimally invasive laparoscopic surgery, if open surgery has still a role. We all know that how difficult it is. Actually, it is not that very easy to take this necrosum out. We all know that we use fingers, blunt dissection, we use sponge holder to remove this necrosum, and we don't have this accessories on the endoscopic side or on the radiological side to do this sort of necrosectomy that is being done on the surgical side. And when we talk about necrosectomy, we talk about close continuous lavage, planned re-laparotomies or a delayed closure, or we talk about open packing and re-laparotomy. But the procedure that is commonly practiced is the close continuous lavage system, wherein after doing this extensive necrosectomy, we put in these drains and start irrigating this retroperitoneal cavity with normal saline. Keep a watch on the content that the effluent that is coming out from this, and also keep a watch on the fluid amylase on this, and continue this irrigation till the entire cavity is cleared. And whenever we have some colonic complications like this rupture into the thing, in addition to the necrosectomy, we may end up doing a diversion ileostomy or a diversion colostomy. And sometimes whenever these patients who have this endoscopic stents placed, and they migrate into the peritoneal cavity like this is done. This is an actual stent that is placed here, migrated into the peritoneal. Sorry?
Yes, yes, sir.
Is my screen okay?
Yeah,
So
yeah, it's
whenever-
okay.
yeah.
Please go ahead.
Drain into the, it is migrated into the peritoneal cavity. So you can see this how we salvage this patient, take this patient for open surgery. And this is the stent that is taken out from the peritoneal cavity. You can see this, that is the lumen opposing stent that is put in a wall of necrosis that is completely not matured. And this is the patient that I operated just day before. Actually, you can see this. I mean, just walled up pancreatic necrosis, a caution to all endoscopists, please. It has to be a very well walled off necrosis. Collections which are anterior to the stomach here, like this. Can you see this actually? This cross-sectional imaging, which shows a walled off necrosis here, a collection anterior to the stomach. Now, this endoscopist has gone in and placed 2 of these stents into this collection, into the anterior to the stomach, and left this as it is. The patient continued to spike here. You can see this cross-sectional sagittal section, which shows this is a walled off necrosis. The stents are put in into this collection into the anterior, which is anterior to the stomach. And obviously, if you put these, obviously they go into the free peritoneal cavity. This is what is, these are the stents which are into the anterior collections here. And this is how, this is the collection that remains undrained. It had to be drained. And subsequently, the patient is doing very well. This patient was just operated a couple of days back. So if you see the overall outcomes of this different open technique, there's an exaggeration saying that the open surgery is associated with a lot of these complications. But if you see the overall mortality is very, very low if these patients are taken up very early, and the morbidity associated with this is also very, very low. So as we're doing this open surgery, minimally invasive surgical techniques came in. Both Manas and Vaiju are masters in minimally invasive techniques doing this pancreatic necrosectomy. There has been a paradigm shift from laparotomy to laparoscopy, and tertiary care centers with sufficient expertise and have started increasingly using these minimally invasive techniques, and is obviously associated with low mortality and morbidity. And when we talk about laparoscopy, we talk about transgastric, retrogastric, retrocolic, retroperitoneoscopic debridements. All potential areas of collections can be accessed by these techniques. Complete removal of the necrosum is possible in a single sitting, and it can be augmented by use of a hand port. I'll show you, actually, I think Manas will show you these videos, transgastric approach. I'll skip these things. But if you see the overall morbidity success rates of various laparoscopic procedures are almost about 90 to 100% with minimal morbidity and mortality in these procedures. And we have a beautiful paper that came in from Prasanna's group. I think so Prasanna must have logged in. Prasanna, this is just to show you your paper of the Indian experience of this laparoscopic necrosectomy. And you can see this beautiful paper to show that the complications associated with this are very, very minimal, and the mortality is about less than 5%. So this is to show that if you intervene, if you do this laparoscopic procedures at an ideal time in a place where we have good expertise, these patients can be salvaged very, very well. So likewise, as we're doing this laparoscopy, retroperitoneoscopy came in a big way. Now, basically, it is necrosis approached by a direct retroperitoneoscope after dilatation of the previous PCD trocar, or by using a primary trocar directly into this. And it can be done in critically ill patient, and there is no peritoneal contamination in this. This is to just show you after the initial CT. Now we just mark out this ultrasound here. We mark out this, and using an OptiView trocar, you can go under the ultrasound guidance. Now that you have marked it, we know that it is very close to the thing, and you can directly go into the walled off necrosis. This is beautiful technology that we have. Actually, we have been using this to gain access into the free peritoneal cavity. Bariatric surgeons using this extensively. You can see this is how you get into the walled off necrosis. Drain as much as possible all the fluid, and then once you've drained this, you can put the standard laparoscopic camera through this and have additional ports inserted beside this, and then do this necrosectomy using the conventional blunt instruments, the suction cannula. And you can see this, we have this large vessels that traverse this retroperitoneum, which can be very hazardous. You can see this, these are large retroperitoneal vessels, and bleed can be torrential from these. And when we do it under this laparoscopic or retroperitoneal approach, we have good instruments to stop this bleed if at all it happens. So once we have done the necrosectomy, we drain this entire thing is drained, and then you can see this. We can put this drain, 2 drains, and then continue to do lavage postoperatively in these patients. This is another patient which was recently done in our department. Just to show you again, we're using this optic view trocar to get into this wall of necrosis. And once you have done this, and then you can let out all the fluid, and then subsequently you can get into this retroperitoneal wall of necrosis, and then insert additional ports beside this, and then you can do a good necrosectomy using this blunt instrument, use a suction cannula, do good necrosectomy, and then completely lavage this area, then put these drains and come out of this. And these patients seem to do very well. And of late, we started using this STEM scope. This is an extension of what we use. This is a very good thing. We get on it's something like a video assisted necrosectomy ward that we talk about, but here we're using a TEM scope here, and you can see this, we have rigid instrument, we get directly into the wall of necrosis, and we're able to do this. So from this optic view trocar, now we switch over to this TEM scope, and we find that it is rapid, very fast, and the instruments we are already used to this, and necrosectomy is very, very safe using this TEM scope right now. And also people have started using a hand port as a single incision to do this debridement. And you can see the patients are very comfortable after this. You put the 2 drains, and then you can continue to irrigate, and there is no drain to the peritoneal cavity. And there is a lot of data which is coming to show that this retroperitoneal approach is safe with minimal morbidity and mortality. And there is a beautiful paper which compares open necrosectomy with minimal access retroperitoneal approach, which shows that this procedure is an ideal procedure if you have good expertise. Now, this is a hybrid procedure that I did in my department, because basically we do both endoscopy, laparoscopy, open surgery. This is just to show you how we can use a combination techniques. I'm using a trocar under endoscopic vision, going through the abdominal wall, anterior wall of the stomach, posterior wall of the stomach, into the retroperitoneum, into the wall of necrosis. Now, you drain off whatever is possible through this. Now, once you have drained this, now we can go into this wall of necrosis, use this suction cannula, then withdraw this trocar from the posterior wall into the gastric lumen. All this is being done under endoscopic vision, and use a standard laparoscopic stapler to create a wide anastomosis here, like what we do in conventional laparoscopy. Now, once you have done this, then you can debride this either using conventional laparoscopic instruments, or you can use an endoscopic debridement to do this. So this is the beauty of using, when you have technology that is available and you have good expertise among different people, we can use this hybrid procedures like this to do the debridement. And if you compare all the minimally invasive techniques that we have, as in today, it is shown that these procedures are as good as the interventional radiology procedure that we talked about. So what are the issues regarding the minimally invasive techniques? Now, the data supporting MI techniques is limited. They're just pouring in right now. Endoscopy is pouring in now. Laparoscopy, retroperitoneoscopy data is coming in. Now, there are lack of well-designed trials as in today. There is lack of widespread expertise, variations in techniques in different institutions, and sample size required to show significant outcome difference is very huge, and centers have limited experience with this. And extension to routine clinical use has lots of limitations. So you can see this, based on these collections, wall of necrosis and extension on this, now we have different preferential techniques that are adapted, right from PCD to endoscopy to retroperitoneoscopy to laparoscopy. So depending on the site of the wall of necrosis, we have to have techniques which have to be devised, and we have to follow this. Now, unfortunately, this is what we talk about. Based on this location, we have to tailor-make these procedures. But unfortunately, the compliance to this is absolutely very, very minimal. Just because a wall of necrosis goes to an endoscopist, it doesn't mean that endoscopic drainage should be done. Just because it goes to a surgeon, it does not mean a surgical drainage has to be done. Please, we have to see what is best for the patient based on the anatomical location, based on the expertise that we have, we have to tailor make this intervention. So in all this, actually, we are talking about interventional radiology, we are talking about endoscopy, we are talking about laparoscopy, retroperitoneoscopy. Now, is open necrosectomy obsolete in 2010? Now, everybody thinks that with so many people seeing workshops, and you feel that there is no role for open surgery. Now, this is a beautiful review that comes from Gangaram Hospitals, which shows that even today, if you see this, all the emergencies, open necrosectomy seems to be one of the commonest procedures that is done in pancreatic necrosis, in spite of having all expertise in the center. Now, this is a beautiful paper that is a multi-institutional paper that is coming from different centers. Now, the biggest thing that you have to see is this: you have all big names in endoscopy, laparoscopy, open surgery, and we have some contributions from Indian side also. You can say that we have people who practice interventional radiology, people endoscopists, surgeons, minimally invasive laparoscopic surgeons, and so this is a beautiful study, which is the practice pattern in 51 hospitals across 8 countries. Now, 1980 patients were studied, and if you see this, majority of these patients underwent open necrosectomy. Minimally invasive surgery comes next, endoscopy comes last. Though we see so many publications coming in endoscopy side, it is not the practice that is practiced in many of the centers, basically because of limited expertise. Again, beautiful paper from our own country in a three-tier city where they do not have access to all this technology. Open surgery still continues to be the treatment of choice. And this beautiful paper, which shows that initially there was a surge with the advent of interventional radiology and endoscopy, there was a shift in interventions from open surgery to endoscopy or interventional radiology. But with more and more data coming in and more of this extended world of pancreatic necrosis being treated, surgery seems to be coming in a big way back into clinical use, and majority of the centers still continue to use surgery. Now, if you see the endoscopic or surgical step-up approach, now both of them have equal, and so though endoscopic step-up approach is not superior, but in this patient, you can see this endoscopy is used for only patients who had walled-off necrosis in good approximation to the stomach, whereas all others are included in the surgical group. And if this beautiful paper, which shows various types of minimally invasive procedures that are used, open surgical technique, laparoscopic debridement, and if you can see the data that is shown that the surgical transgastric necrosectomy, this is comparable to the endoscopic transgastric necrosectomy, is an excellent one-stage option for symptomatic one in highly selected group of patients. Now, if you run a randomized controlled trial, we have to have a randomized trial between surgical transgastric necrosectomy, or in today's practice, it has to be laparoscopic transgastric necrosectomy versus endoscopic transgastric necrosectomy. Now, this is a beautiful paper that came in from All India Institute of Medical Sciences, wherein they have shown, they have done one. They compared endoscopic and laparoscopic method. Now here, mind you, the selection criteria is less than 30% debris. Now in this, when they had this walled-off necrosis with less than 30% debris, they showed that both laparoscopy and endoscopy are similar, and the choice of procedure depends on expertise and patient preference. And so such a heterogeneity of interventions that we have. So initially, even in our department, whenever walled-off necrosis used to come, the patient used to go to the endoscopist for an endoscopic drainage. But so subsequently, we realized that this cannot happen because a lot of patients had some post-endoscopic complications because of inadequate drainage. Now we have a pancreas board. We have a healthy discussion that happens between physicians, surgeons, and the radiologists, and we start deciding which patient has to go for endoscopy and which patient has to come for surgery. If you see this data from our own center, 2010, when the Panther Trial came in, all the radiologists became very aggressive. There were hardly any primary surgeries coming in, hardly anything. But with the advent of endoscopy, slowly some of these patients started going for endoscopic ultrasound and drainage. But at the same time, as we started introducing this medical pancreas board, you can see this more and more of these patients started coming for primary surgery because of the extent of all of pancreatic necrosis. We have increasing number of patients who are coming in for primary surgery as of today. And if you see our own data, patients who come for primary surgery, the mortality is very low. Patients coming post-PCD because of infectious complications, the mortality is high. And we find that whenever patient comes post-endoscopic ultrasound, the mortality is very, very high. So patients, if you select them and they come directly for surgery, be it laparoscopy or open surgery, the mortality is very less. So to conclude, the management concepts of walled pancreatic necrosis evolved and standardized from conventional surgery. Surgery continues to be the standard of care because of several limitations of minimally invasive techniques and compliance issues. Primary surgery, including laparoscopy, retroperitoneoscopy, are associated with good outcomes with low morbidity and mortality. Interventional radiology and endoscopic failures require open surgery. This is very clear. Once interventional radiology and endoscopic therapy fails, now these patients cannot be considered for laparoscopy because localization and complete necrosectomy becomes impossible on laparoscopy. So all these IR failures and endoscopic failures end up with surgery. IR and endoscopic failures are associated with increased morbidity, as I've shown you, basically because of a lot of septic complications and basically because of nutritional factors. And surgery seem to be complementing interventional radiology and endotherapy. So as in today, the walled up pancreatic necrosis intervention depends on expertise, technology available, patient status available, anatomical extension, and the patient status, what I mean both the functional status and the financial status. You cannot be experimenting with these patients. This is a beautiful article which has come. I'll just read it with you. Many different interventions in varying states of evolution are available for treatment of pancreatic and peripancreatic necrosis in 2020. These interventions should be offered in the context of optimal intensive care and medical management, and that a multidisciplinary approach is required in a center with specialized expertise. You have to decide which intervention is the best for this patient. So if you see, I'll just summarize this. If you have a walled up pancreatic necrosis, in good approximation to the stomach and duodenum, it is less than 30% debris. Some of the endoscopic series, they say less than 50%, but majority of them say less than 30% debris. Then you can do endoscopy. But it is more than 30 or 50% debris. These patients require open surgery or laparoscopy depending on the expertise that is available. Very clear. We have a lot of data. If you have more than 50% debris in these patients, please do not take them for endoscopic treatment. Take them for open surgery or laparoscopy. Now, if these are not in approximation to the stomach and they are beyond the stomach and duodenum, now if it is more than 30 or 50% debris, these patients can be subjected to radiology procedure or a step-up approach or an open surgery or a laparoscopic approach. If it is more than 50% debris, patient is sick, unstable, you do a radiological step-up approach. If it fails, you do an open surgery. If it is a stable patient, you do a radiological approach, and then if it fails, again, open surgery. Now, if the more than 30% debris, the patient is very stable, you can either consider a lap or an open procedure depending on the expertise that you have. So this is a beautiful summary of what an endoscopist has summarized. This is Shyam Varadaraju's group, who suggested that if you're having a target like this, all these with good approximation to the stomach, absolutely, or into the duodenum, these are the patients who are ideal for endoscopy. Now, as the world of necrosis extends beyond the stomach and duodenum, we can see this other procedures like interventional radiology and surgery come into vogue. So it is very clear, patients who have extensive extensions into paracolic gutters, mediastinum, these have to be treated by surgery, or if you have good expertise, interventional radiology procedures. Endoscopy is limited only to patients who have good approximation to the stomach or to the duodenum. So basically, it is, as in today, it's a part of a multidisciplinary deep approach between HPB surgeon, endoscopist, and radiologist, tailored to the anatomic location, comorbidities, and available expertise. but also we should not demean the importance of critical care intensivist who manages all these patients. I think a close coordination between a critical care intensivist is very, very important. And it is very clearly written that together we stand, divided we fall, especially in the management of these patients with acute pancreatitis. If you fail to do a multidisciplinary approach, obviously I'm sure we'll lose our patient. So I made this start for my department almost 10 years back. I'm hoping that something like this comes and the clinical use, something like a robotic stuff which comes in, makes a incision in the posterior wall, sucks off all this necrosum, and uses the zipper that we used to use initially for zipper laparoscopy. Close this, and then whenever we have a collection, go in and open this zipper, do this necrosectomy, and closing this again. This is the fantasy thing that I dreamt of almost 10 years back. I think it may become a reality with the advent of more and more of these interventional procedures. Thank you once again for the patient hearing both the entire outlets.
Fantastic presentation as always, Dr. G.V. Rao. And I think it is the elaborate discussion about pancreatic necrosectomy, endoscopy, percutaneous, retroperitoneal approach, and laparoscopic approach. I think Dr. G.V. Rao is the ideal person to present this topic because he is heading a unit of surgery where everything is available. So probably Dr. G.V. Rao has shown some studies from Nandi's group showing open surgery as the ideal thing, and from the AIIMS group only, Dr. Bensal's group is showing laparoscopy as the ideal thing. So it differs from place to place. So Dr. G.V. Rao's place is the place where interventional radiology is available, and good interventional endoscopy is available, and good surgeon is available. Probably the last slide, which is he has shown, that the algorithm of treatment of pancreatic necrosectomy should be followed in other centers also, where all the armamentary is available. Now, there are not much questions in the chat box. Let me start the questions by asking you. You have mentioned in one of the slides that the critical care manager will be the primary physician, but that may not be the case in all the institutions. So, if a patient comes to you with acute pancreatitis, with or without necrosis, who is the first treating physician, whether the surgeon or the intensivist or the medical gastroenterologist? Can you please unmute?
Please unmute it. Yeah.
Thank you. The practice pattern seems to vary from center to center, actually. But in our center, basically, it goes to the critical care and the medical gastroenterologist. Unfortunately, we have a pancreatologist with us. Actually, these are the people who deal with the thing, but the surgeon is also kept in the loop about the overall management, actually. So all of us keep the patient.
Is that in the final stage of the treatment of the patient, or you will be included in the first stage itself?
No, we are involved in the first stage initially. We are involved in the first stage of the management. I mean, all of us see all the patients with this pancreatic necrosis stage actually. Initially, we had some the discussion about this, but now actually, all of us have now come to a common understanding that all of us have to be involved in the management, so that any given period of time, suppose the patient comes first, obviously. Suppose if any other intervention is required, we make sure that it is.
That's an ideal method that you like to involve the surgeon also into the scenario in the first setting itself.
Yes.
My second question is regarding ERCP. It's a bit different from your topic. Suppose a patient comes to you with the elevated amylase, lipase, and you are done on MRCP, but the stone is not there, and the gallbladder is having some stones. Will you put in a stent, or you will wait for the pancreatitis to settle for the cholecystectomy?
The indication for ERCP is very clear. Unless and until the patient has cholangitis, we are not going to do any ERCP in these patients actually, and we are not going to put any stent. The indications of ERCP is very clear. Initially, we used to put in stent for all these patients, but now, absolutely, unless and until the patient has cholangitis, we don't do any intervention of any sort for these patients.
Okay. Second question is fluid collections. Fluid collections, will you drain? Because most of the endoscopists tend to drain all the fluid collections which is coming in. What is your practice actually? You decide on draining all the fluid collections with endoscope, or?
No, actually now there is a lot of data which is coming in to show that unless and until the patient is symptomatic or any complications because of this peripancreatic fluid collections, we do not wait. Actually, when we were students, we used to talk about the rule of 6. But now all that is gone. As long as the patient is not symptomatic, we just closely observe these patients actually. The intervention is only when the patient becomes symptomatic.
Yeah, very good.
Causing any mechanical obstruction.
Now, US is a center where a lot of years, I think you must be doing more than 60 or more than 100 ERCPs a day. Do you find any difference between ERCP-induced pancreatitis and de novo pancreatitis that is leading to necrosis?
Yeah. Fortunately, actually, what you said is right. Actually, the incidence of why I was against now ERCP. Actually, if you see, Nagi will make a very good comment saying ERCP is a dangerous procedure. Now, after 30 years of experience, now we'll say ERCP is a dangerous procedure, especially when it's not indicated. So these patients actually, definitely, the ERCP-induced pancreatitis sometimes can be as fatty as any other pancreatitis. They can be extensive pancreatitis. Majority of them have mild pancreatitis.
Necrosis.
Patients who have absolutely very bad necrotizing pancreatitis.
Is there any difference between the management of ERC-induced pancreatitis?
Now, ERCP, absolutely. Now, basically, now there are a lot of preventive measures that are being taken to prevent post-ERCP pancreatitis, especially in high-risk patients. Now, they started doing rectal indomethacin. So the incidence of post-ERCP pancreatitis come down dramatically. Now, as far as management is concerned, the surgical, it all involves the same principle. It does not change actually. It absolutely does not change the management, whether it's post-ERCP pancreatitis or alcoholic or alcohol-induced pancreatitis. Pancreatitis is managed in the similar way.
You are talking about a hybrid method of retroperitoneoscopy and endoscopy. Have you done a laparoscopy combined with retroperitoneoscopy?
Yeah, I showed, okay. Now this actually, we had one case wherein we drained the wall because it was pointing onto the retroperitoneum, we did a retroperitoneoscopy. But basically patient being a Gaussian pancreatitis, we have done a laparoscopic cholecystectomy. But we haven't done a combined procedure wherein I combined laparoscopy and retroperitoneoscopy. No, I've not done. I think, Baiju, do you have any experience, Baiju, actually?
No, actually, I was just wondering whether that will, laparoscopy and retroperitoneoscopy together will save some patients.
Maybe we'll have to see that, actually. I'm not very sure.
And you are showing, the last 2 slides, you are showing some head-to-head comparison between the endoscope. But is that it's a head-to-head comparison between endoscopy and laparoscopy, or endoscopy versus open, or is it that 2 centers?
No, actually, the data that is randomized control trial has come from All India Institute of Medical Sciences comparing endoscopic transgastric necrosectomy versus laparoscopic transgastric actually from Piyush and this group, and that's it is less than 30% debris. They say the results are absolutely the same. It all depends on whatever expertise that you have. That's the AIIMS study that has come actually.
Yeah. There are some questions in the chat box now. Dr. Arun S. Nair, he is from Kerala only, he is from Trichur. For a horseshoe wall of necrosis with a large collection, limb in the paracolic gutter, with less retrograde collection, but necrosis more in the peripancreatic area, which is the best approach. We can see the chat box if you want to see.
Yeah, I think I made my algorithm very clear actually. See, it all depends on whether the functional status, the clinical status of the patient. If the patient is stable, these can be taken up for either intervention. If the necrosum is less than 30%, you can take them for interventional radiology procedure. If the necrosum is more than 30-40%, actually, then I think surgical drainage is the best procedure for these patients. But the patient is clinically not stable. Maybe you can just put in a drain initially, let the patient stabilize, and take the patient for surgery subsequently.
Yeah, there is another question by Shiba Shrestha. Management of post necrosectomy persistent pancreatic fistula. That is an important topic which you didn't cover actually.
Yeah. Now this is a very good question actually. Now this whenever this patient undergoes a endoscopic or a or a laparoscopic transgastric or you're draining into the duodenum or into the jejunum, these patients obviously will not have any pancreatic fistula. Now, whenever you're draining these patients outside, now these patients can have pancreatic cutaneous fistula. Majority of them again seem to settle down spontaneously until a 10% of these patients who seem to have a total disconnect between at the pancreatic in the pancreatic duct. Now we have two issues regarding this. Actually, majority of these patients initially we used to do surgery if the drain is more and a significant amount of pancreas is draining outside. These patients used to go in for surgery, wherein we used to do a fistulojejunectomy, or if only small pancreas remnant is draining outside, we used to do a distal pancreas.
Yes, any role of ERCP that time?
Yeah, no, I tell you. Now, of late, what happened was, actually, I have a beautiful, day before we had, suppose there is a cutoff and the distal pancreatic duct is dilated. Now, the endoscopic ultrasound, they're able to make a fistulous communication between the stomach and the distal part of the pancreas. So they're doing a EUS guided pancreatico-gastrostomy. And even if you're putting a small stent, that seems to help a significant portion of these patients.
Will an ERCP help in that patients by a prograde drainage of the pancreatic fluid?
Now, if it is supposed that the pancreatic duct is intact, and if it is a very small stricture, and you're able to put a stent across, it is possible. But many of these patients with this persistent fistulas have fibrotic long strictures, which may require, if the expertise is available, an EUS guided drainage into the stomach. Or they may require surgery in the form of a distal pancreatectomy or a fistulojejunectomy.
Yeah, Dr. Harshavardhan has asked about any data about the total percentage of pancreatic necrosis which is not endoscopically accessible.
See, it is something, this is a very good question that you asked actually, but if you see in surgical practice, actually, I've shown you my own data, it shows almost 30%, 30 to 40% of the patients seem to have necrosis which is beyond endoscopic drainage. Majority of these patients, actually almost 30 to 40% of these patients have this pancreatic necrosis which extends beyond the stomach of the duodenum.
Yeah. There is another question by Naveen Jain that is already answered, I think. US guided gastroscopic necrosectomy already answered during the lecture itself. I think there are no other questions from the audience. Once Dr. Suman Roy has asked about how much common or prevalent in routine practice to get cystic neoplasms as acute pancreatitis.
Cystic neoplasm causing acute pancreatitis. Yeah, the cystic neoplasms causing acute pancreatitis. The pancreatitis is usually very mild. Most of them can be managed conservatively. But cystic neoplasms causing necrotizing pancreatitis, I have not come across. I have not seen any patients who come with severe necrosis.
Yeah. And that is, I think, that is the end of the question is from the chat box. If anybody wanted to ask directly, can ask, unmute their mic and ask Dr. Jivarabu. He'll be happy to answer the questions. I think there are no questions from the audience. Now, thank you once again, Dr. G. V. Rao, for the excellent presentation. We loved the presentation, especially the algorithms or treatment, especially when you are coming from a multidisciplinary approach to hospital. The algorithm is very important for the management of our day-to-day practice.
Baiji, your internet is getting unstable, maybe. Okay, GV, in fact, that was a fantastic presentation. You clarified everything, all aspects of pancreatic necrosis. In fact, your last slide was really an eye-opener, that all those fantasy that you think of is a fantasy today will be a reality tomorrow. So, in fact, probably Baiju is now frozen because of his internet instability, maybe. So, we'll be going on for the next presentation. So, GV, you can just stay back. I think questions have already been all covered. So, I'll be making, is my screen visible now? Is my screen visible now?
Sir, visible.
Yeah, fine. Thank you. So,
visible, right?
Yeah, fine. So I think after that extensive discourse on infective necrosis, I'll be just making a very simplified thing on how you manage laparoscopically the tips and tricks of this pancreatic pseudosis and the world of necrosis. Just prior to that, for my younger colleagues, just have a broader perspective of things. It is a well circumscribed fluid collection, no associated tissue necrosis, present more than 4 weeks. And Atlanta classification, in fact, has done everything clear collection of pancreatic juice enclosed by a wall of fibrous tissue, but there is no mention if it can include solid component or not. Pseudocyst is without necrosome, and world of necrosis is post-necrotic collection with necrosome. And that has already been very much nicely clarified. So I am not going into all the details that GV has extensively covered on this chapter. These are the various locations that it can happen, starting from lesser sac to mediastinum to scrotum to thorax. But more often we encounter scenarios in the lesser sac, and what we'll be discussing on the lesser sac only. So the management of a pseudocyst, majority of them, they have a spontaneous resolution in 6 weeks time. But if it persists and it persists with the distal structure and MPD, or it persists, the proximal communication is there between the MPD and the pseudocyst, then probably you need to relieve some kind of when they're symptomatic, they need to be relieved. So the two indications to treat these patients, you need to relieve the symptoms or you need to treat the complications. So the management, if this you have to treat the cyst more than 4 to 6 weeks old concept, that has already been told that all those 6 formula that is gone, that was an older kind of a thinking. So you have to balance the risk of complications while waiting for the wall maturity and all. That's in fact is a necessity for a surgeon when we are planning to go for a laparoscopic approach of managing all these cysts. So in India, asymptomatic pseudocyst less than 7.5 centimeter in diameter without any internal debris will resolve spontaneously at an average of 5 months. And the surgical options, as has already been detailed, it can be laparoscopic management or endoscopic, but we'll be focusing more on the laparoscopic part of it, either cystogastrostomy, or if it is towards the tail side, you have to go for a Roux-en-Y cystojejunostomy. These are the two things probably very commonly they are performed. So these are the features determining the treatment. Whether the thickness, people are there for stapling the cystogastrostomy, people are there for suturing cystogastrostomy. But I basically always prefer suturing a cystogastrostomy much more than stapling a cystogastrostomy, and that's in fact is much more convenient. That I'll be going on in detail. I think, but GV has already clarified this thing. Is my slide not visible?
Somebody else is sharing, I think.
No, sir.
Or it's not visible?
Sir, you have to again share the slide, sir.
Again, somebody has started sharing.
Oh, I need to pin it here. Okay, just a minute. Is the screen coming now? No.
Yes, Beju. Yeah, Manash, it's
No,
coming
sir.
now.
Yeah.
Take it, yeah.
Okay. I
Yeah,
think
yeah, yeah.
GV has very categorically told the things that this management of these patients is and entirely depend on these three P's. Where the patient lands up. In fact, if it's not a center where you have physicians, gastroenterologists, surgeons, interventional radiologists all in one place, then things will be much better and they're much better managed. So essentially, it depends where the patient lands up, what is the pocket of the patient, and where the place and the expertise. In fact, that is also equally important because management is most often and quite often are multifactorial, but we'll be focusing more on the surgical treatment aspect of it. So most important factor determining is this treatment is the local expertise. That's in fact very, very important. So we'll be going straightway to the cystogastrostomy and the cystojejunostomy. We just need to watch how it is to be very conveniently done. So this is the world of necrosis. So this is the cyst tenting the stomach. There's the anterior wall of the stomach being tented up. So the essential part is you need to do an anterior gastrotomy. And once we do an anterior gastrotomy, and it has to be done quite a good anterior gastrotomy, and the most important thing is you need to plicate this anterior gastrotomy so that you get a good field to play. So that's very important. It in fact makes your life very comfortable. So once you plicate the margin of the anterior gastrotomy on both sides, it makes the entire posterior gastric wall with the cyst tented up and makes the job very easier and very comfortable. Then it is just aspirated and confirmed. You can see the dark colored fluid coming up. Then a central stitch is taken. This in fact aids in hitching the stitch and making entry into the cyst with a harmonic. Later on, this can go for the histopathological study as well. So that's the posterior wall of the stomach and the cyst wall all taken in a disc is quite a, you need to make a good opening. And that's in fact another beauty when we compare endoscopic approach to laparoscopic approach. In endoscopic approach, probably GB showed a nice one that self-expanding metallic stents and those lumen approximating metallic stents, they're good. But here you know that you can make an excellent opening, you can make a wider opening, you can suture them well. That will be in fact much more pleasing from a surgical point of view. So once you have made it opening, you have aspirated everything, then you make the opening wider. So you have got a sizable opening now. And once that is done, then the next comes suturing the margins. So that disc of tissue is always sent for a histopath. And after the debris have been cleared, then the needle goes in, ensuring that you take the posterior wall and the cyst wall. So it becomes very comfortable because of the vision, because of the ease of operating, and that comfort zone is always there while dealing with a cystogastrostomy. It makes things much more simpler and much more easier. So now the suturing on the thing is complete. Then just an extra mucosal closure of the anterior gastrotomy, single layer closure is good enough with PDS. So that completes the procedure with the closure of the anterior gastrotomy. Now coming to cystojejunostomy, when the cysts are placed on the tail end of the pancreas, then this is a huge cyst towards the tail end of the pancreas. So as the first step of the procedure, a good adhesive lysis is very much important. That's very much required. So once the adhesive lysis is done, the whole cyst is in view now. So before attempting the cyst, the best thing is to harvest the jejunal loop, because anyway you are planning a cystojejunostomy. So a rent is made, the jejunum is divided. So you need to mark the distal end always. That makes things much more comfortable. This is just widening the mesentery little further. And after it's done, it's always ideal that the distal loop should be marked with a suture or a clip, something like that, so that it doesn't make any error and for the future anastomosis. So it's just a marking suture. Then now the cyst is aspirated. So it's under tremendous pressure. So after everything is aspirated, then it need to be enlarged, the opening need to be enlarged. Then you can view inside the cyst with passing the scope inside the cavity and clearing all the necrosum, whatever is there. But it need to be very soft debridement. You need not be very aggressive in this. So after that, you just go for the first layer suture. The distal loop is already marked. We know that the distal end is there. So these are the anchoring suture on either end beyond the anastomosis. So opening is enlarged just to match that it should be a comfortable drainage. That's jejunotomy. That goes on and that completes the cystojejunostomy.
Presentation break up now. Thank you, later 9
So after the cystojejunostomy is completed, the next and the last step of the procedure is to go for the enteroenterostomy. So in fact, laparoscopy makes things much more simpler, much more comfortable to do, and that's the stapled jejunostomy you need to see and check. And finally, the mesenteric window closure, rent closure. So that's the completed row and Y cystojejunostomy. So to conclude, type 1 cysts can be managed conservatively, type 2 best managed by internal drainage, and type 3 needs decompression and relieving the stricture with drainage. So thank you very much for your kind attention. So Baiju, you can take over. You are not audible, Baiju. You are not muted, but not audible. No. Somehow your audio we have lost. You are visible. Somebody, Jagdish has asked about the port positions. In fact, there is no definite port placement at positions earmarked, but quite often, I think in my video, should I show it once again? Just a simple. I think I had shown it probably in the cystogastrostomy side. I think the port positions have shown. This is the port placement. There's no fixed landmark to have your port placement, but more and quite often you need to tailor make your ports. This is a 3-port technique essentially for doing a cystogastrostomy, but for cystojejunostomy or ONY, you might go for 1 or 2 more ports. So that's not an issue. Even though there are no fixed port, your triangulating approach has need to be just well, so that you need your central optic port somewhere supraumbilical, and the other two working ports are one on the epigastric side and one on the right flank, so that this placement and the surgeon standing to the right of the patient, monitor and towards the left shoulder of the patient, things become much more comfortable in doing a cystogastrostomy. And for cystojejunostomy, quite often I always stand between the legs, monitor at the head end of the patient. So this is towards the, how you put your ports. There is how do you create pneumoperitoneum? In fact, pneumoperitoneum, you can always go it's absolutely not a problem, because quite often both the things are on the upper part of the abdomen. So creating pneumo is absolutely not an issue at all. Baju, are you audible now? No, you are still not audible. Some or other we have lost your voice. Anyway, Soman has asked to GV, how do you approach a stable patient symptomatic with cold of necrosis with borderline AKI or CKD? Which one? MRI, US, USG for decision making to treat these subgroups if of patients, as imaging is the deciding factor. So GV, you answered this first, then there is another question for me.
Sorry, I didn't get the question actually. Can I just?
Could you, Soman, could you ask directly? Yes.
Yeah.
Yeah.
GV sir. Yeah, sir. Am I audible, sir?
Yeah.
Yeah.
Sir, there are certain particular subgroup of patients who can come with borderline AKI where we can do CCT for decision making, and we know on ultrasound there is a walled up necrosis, and we want some approach. So the patient needs treatment.
I can understand.
Because even contrast MRI can't be done.
So basically now what we want, suppose if you're not able to do a CT with the contrast, especially after the 6 weeks has passed, I think even a plain CT should be good enough. But if you have facility for an endoscopic ultrasound, I think that will solve the issues regarding what type of drainage can be used.
Sir, as sir traditionally has been told, ki MRI is better delineate the debris, the amount or the characteristics. Yes. Is it helpful or CT?
No. Between endoscopic ultrasound, CT and MRI, endoscopic ultrasound seems to be the best. Between CT and MRI is better.
Okay, sir, if expertise is available, though US is the best. Okay.
For debris, suppose, basically it is now, that's what I'm saying, no? The entire thing is based on the 30% debris or the 50% debris that you talk about. See, Manas has shown you the beautiful video. All these videos, all these are usually all pseudocysts only, with minimal amount of debris which we used to drain. So now, but technically they become walled of necrosis now. So basically, it is basically now predominantly going, because every patient seems to get an endoscopic ultrasound now, so all of them become walled of necrosis.
Yeah, absolutely.
Okay, sir. Okay, thank you, sir. Sir, Manas, sir.
Yeah, you have a question for me. When do I start oral diet after cystogastrostomy? In fact, starting oral diet, the next day with liquid and the next day with solid diet is absolutely not an issue. It's absolutely not a problem in a cystogastrostomy. In a cystojejunostomy, same way, once the bowel starts moving, you can put the patient on normal diet. Is absolutely not a problem. So sooner we start oral, it's better for the patient.
Okay, sir. Sir, in VAD, sir, any specific interop, any tricks to avoid colonic injury? That is the most disaster for any surgeon. VAD, sir.
This is a very good question actually. Suppose if you have had, these are best done under, you should have a good CT. And best under, even when you're doing these procedures, I think you should have an ultrasound guidance to make sure that you have a good ultrasoundologist who can really guide you. But again, you're very right actually, especially when you're dilating the tract very rapid. If you're dilating the tract over enthusiastically, and if the colon is right beside the thing, it is likely that you can end up with trouble. But you should have a very good cross-sectional imaging before you try any of these procedures.
I think guidance always guide you better in this kind of scenario. Otherwise, you might land up in the colon unknowingly and unintentionally.
Yes, sir.
Unintentionally, yes.
Absolutely. Absolutely.
Sir, can I ask that
Sure,
point?
sure.
Sir?
Please
Another
go
point?
ahead, Somen.
Sir,
Yes.
sir, in majority sir cases in VAD, we routinely use step-up approach after a percutaneous drain, and as a surgeon, we go through that drain only. Retroscopy, it will be safer.
Yes.
But even with that, sir, sometimes colonic injury can happen. So
Yes,
is it,
absolutely.
sir, you use a finger approach or optical trocar would be better? Which one is more safer? Matlab, for a, even if there is a percutaneous drain is there.
So I personally would, with so much of expertise right now with the trocar and also with the TEM scope that we have, actually I would rather be happy putting in a trocar rather than trying to put in a blunt finger and trying to do the dissection. And once I'm inside this thing, then we can use the other instruments actually.
Okay, okay. Thank you, sir.
I think OptiView plays an excellent role in this.
Excellent. And we have the even wide bore trocars are available right now. Actually, all these trocars can be used very liberally for this thing. Actually.
Yeah, true.
Okay.
Yes, Nausif, you have any questions? Yes.
Sir, Rao sir. Sir,
Yeah,
you have shown your data. So in that, you can notice a lot of patients had, majority of patients had primary surgery. So what were your choice of going for that?
No, not majority of all these are patients who have been outside, patients who have got necrosis extending beyond the stomach or duodenum. You understand what I'm saying? These are the patients. Actually, our endoscopic series are the huge one. Actually, they have patients running into thousands actually. So these are patients which are selected, which are extending beyond the stomach and duodenum who come for primary surgery. What I meant to say is, initially the numbers were very less because all of them were going for endoscopic drainage and insufficient drainage. They used to come for surgery. But now we have very clearly stated that these patients would go for surgery and these patients would go for endoscopy.
Okay. So one more thing, one more question, sir. There is a concept like whenever you contaminate the peritoneal cavity per se with the necrosum, you are going to increase the mortality risk of this patient. So what is your take on that? When you have to base with retroperitoscopy as well as this thing, laparoscopy. So
yeah, this is a very good question. Actually, now this is where what Beju has raised a question actually comes into this thing. Suppose we are doing a retroperitoneoscopy and see, basically, whenever we do this retroperitoneoscopy or any of these things, unless and until you have a good ultrasonologist with you, I don't think you should attempt all this. See, we may be thinking that we have removed the entire necrosum, it may not be complete, but I think we should have a good ultrasonologist along with you. Suppose there is any doubt of any peritoneal contamination during this procedure, I think an additional laparoscopy procedure, what Beju has said, would be mandatory to lower. You cannot just leave it as it is because it will drain into the peritoneal cavity and it will be catastrophic. So if there's any suspicion of rupture into the free peritoneal cavity, I think an additional laparoscopy or an open surgery is mandatory. I think Beju, what you said is absolutely right. Actually, a combination of this is very, very important when it comes to.
I think Baiju is not audible. That's the problem with Baiju. He is only visible. He's a superstar, so he's only visible, not audible. Baiju. You have made some technological change, Baiju. So yeah, we are able to see you laugh. We are able to see your lip movement, but we are not able to hear you. Anyway, so anybody else, any questions? Please be visible, and you can always go ahead. Siva Srestha has asked another question. Symptomatic, just a minute. Symptomatic extended wall of necrosis on lesser sac, bilateral paracolligator. How will you create cystoenteric anastomosis and how many? I think Jivi, you had cleared this in your presentation when you have got extra.
Yeah, right.
Yeah. So please take on this.
So basically, see, it all depends on whether you're getting a dependent drainage or not. Suppose if it's the whole thing is communicating, Suppose there are multiple connections which are not communicating to each other, then we may require a single or a double anastomosis, as what Dr. Manash has shown you. But suppose if they're all connected together, yes, a single drainage could be sufficient. But again, if a large collection, paracolic collection, and if you think you're not able to drain that, then I think you have to go for a surgical drainage, not do any endoscopic drainage.
Yeah.
Because suppose once you create an endoscopic drainage, you'll have a gastrocutaneous fistula persistent. So the procedure has to be very, very clear what you're doing actually. Suppose paracolic extension, I think best would be to do only a retroperitoneoscopic or a step-up approach or a surgical drainage in this patient.
I think
Am I audible now?
yeah, you are now audible. Yes, Baiju.
I logged out and came in.
Okay. So I think the single line answer for this problem is whenever you have a hammer in your hand, everything should not look like a nail.
Yeah, absolutely right.
So
I have
yes,
a question for you, Manash.
yes.
How wide the opening should be?
It's around 6 centimeter, 5 to 6 centimeter minimum.
Many a time when you do an endoscopy postoperatively after a few weeks, we have seen that most of the time the posterior wall is closed, opposed together, and probably some small fistula might have been there. So, is it that the purpose of the cystogastrostomy is served for a few weeks only, or what is your this thing?
I think essentially it all depends upon solving our purpose. Our whole purpose is to get an early drainage. And once we have made a sufficient wide opening, and once it has already been drained, then both the walls they get opposed. So it doesn't matter whether by that time it's all fibrosed, it's all fused. Doesn't matter whether the opening by that time is closed or open. Because quite often, I think residents keep asking this question that if you keep a wide opening and patients start taking food and all, does the food enter there into that cavity or not? But it hardly ever it can happen, because essentially we want a good opening. It needs to drain out everything. And by that time, 4 to 6 years, when you're going for a review endoscopy and you see the opening is closed, it doesn't matter. Our purpose is solved. We have achieved our target.
Yeah, another question for you is that suppose you have multiple symptomatic cysts, not in the retrogastric area, but somewhere else, of fluid collections, which is walled off.
That was exactly now answered by GV.
No, I didn't get you.
That was, in fact, that's what we told. I mean, if all things they are communicating to each other, then it's fine. One anastomosis might solve the purpose. If not, you might go for 2 anastomosis. And if not, then it has to be a combination of procedure. So not that one procedure will be sufficing for everything that you encounter. That's why I was telling that when you have a hammer in your hand, everything should not be a nail to you. You have a laparoscope in your hand, you should not attempt everything. You must tailor make the things that will suit best to the particular patient.
One question to Dr. G.V. Rao regarding placement of drains. Previously, we used to keep whiteboard drains both sides of the plank, and then we used to irrigate. So, what's your present practice?
Now, if you're doing an open closed lavage system, whenever we're doing an open surgery, we do a closed lavage system. We put 2 drains and irrigate the thing. That's the standard of care. There is no doubt about that actually. We don't do this packing and re-laparotomies now. I think the best method that is practiced across the globe is that closed lavage system, where we do a good necrosectomy, then put 2 whiteboard tubes and start irrigating on the 3rd post-op day till we get a clear fluid from the other drain, and we keep a close watch on the fluid amylase.
You finish the irrigation till the culture is negative, or just the debris is absent?
Till the debris is clear, and then we do a cross-sectional imaging, make sure that there is no residual necrosum, and then we remove the thing.
Okay. Sir, I have one question, sir.
Yeah, please.
How to approach if the word of necrosis is anterior to the stomach, or just below the liver, between the gastrohepatic ligament area?
Yeah, these are best. Suppose if the debris is suppose the debris is less than 30%, I think you can do an interventional radiology procedure and tackle this thing. But if it is more, I think laparoscopy or open surgery is the best.
Sir, most of the time the colon will be stuck to maybe also a part of the this cyst. So minimal, is it have to go open or we have to in this we can do still minimal access?
Again, it all depends on the expertise that you have. Suppose if it goes to Beju, I think he'll never ever open the thing actually. So it all depends on the expertise that we have actually. So basically, but again, I mean, the word of caution to all younger surgeons is please don't be very aggressive in these things, please. You should know your limitations and then you should, there is no harm in opening the patient, please.
Absolutely.
If you don't have the expertise, please do an open surgery, absolutely, in the interest of the patient. But once you develop expertise, then I think slowly you can step up your procedures to more advanced procedures and become more aggressive.
I think the bottom line should be primer non-nocere. You should not do any harm to the patient. It doesn't matter. This can very comfortably done laparoscopically as well. But if you are starting off, you are not sure. Absolutely, as Evie told it, please don't hesitate to open. Open surgery is not ruled out absolutely in the minimal access era. So the first thing is you need to make things comfortable to the patient. So and it should have a very good recovery. That is the most important.
Dr. Subhash Dharich, do you have any questions to ask? You can unmute.
You can unmute, sir. You can unmute. Dr. Subhas, you can unmute.
Please unmute.
You are muted, Dr. Subhas. Yeah.
No, he is not unmuted.
He is not unmuting here.
Anybody else having a question?
Jaypala Reddy, you have any question?
No, sir. No.
No. Okay, fine. Anybody else?
Sir?
Yes.
Hello.
Yeah.
Yes.
Sir,
Yes.
am I audible?
Yeah.
Sir, in post necrosectomy, like acute pancreatitis fistula, pancreatic fistula, those are persisting. Sir, when those 10-20% cases, when you intervene, majority is subsides. When you intervene for those pancreatic fistula, means when you decide to, okay, we need to go in, or either it is endoscopic or surgery. Means after how much time you should wait?
Yeah, there is no specific timelines that are given for this in any literature actually. Basically, suppose if the output is high and it's continuously causing excoriation of the skin, anything of that sort. And I mean, obviously, see, anything that does not seal off within about 3 or 4 months, about maybe 8 to 12 weeks of time, I think these are the things which require some sort of an intervention. You cannot, I mean, suppose if it does not heal after about 8 to 12 weeks, I don't think it will heal permanently. I mean, the output is high. Obviously, these patients require some sort of an intervention.
So we should wait for longer time, basically.
Yeah, basically now the endoscopists have started doing another technique. Now what they do is actually if the leak is very high, they remove the drain, allow the fluid to accumulate, and then do an endoscopic put a drain into that cavity so that it drains internally. So that is another procedure that is practiced. So all non-invasive things should be practiced. So intentionally we remove the drain and allow the fluid to accumulate there and then strike it with endoscopy so you have an internal drainage. So the role for surgery right now, I mean in the last few years, I think we would have operated maybe about 4 or 5 patients, actually not many actually. I know Beju's experience with this, maybe 4 or 5 of these patients with pancreatic cutaneous fistula, because most of them are being tackled endoscopically right now. Self-limiting or being tackled endoscopically.
Absolutely. Professor P.K. Saha, sir, you have any questions?
Dr. Subhash has raised a question regarding pancreatic fistula. While waiting for it to close, we can refeed the juice through the Ryle's tube.
Yeah.
Well, Very good question. Actually, this is a very good question. It all depends on how much of, because usually majority of the time, whenever we have this leaks, pancreatic or cutaneous fistula, it is basically from the distal pancreas actually. So very hardly ever we had anything where you had to significantly refeed like what we refeed the bile in some patients actually. So I don't think it causes that amount of pancreatic insufficiency to refeed these patients. There is no data to show anyway. I don't know there is any data to show refeed the pancreatic goods.
No.
I have not read any regarding that.
I think for bile, it's quite often done.
Yes.
Biliary fistula, it's quite often done.
Yes, right.
I think now it is 9:30.
Doesn't matter. I think I have one question for you, Baizu. When you decide to go for a transmesocolic approach in a pancreatic pseudocyst?
Actually, the cyst is the content of cyst is dependent in the lower part. Means if you can drain by transmesocolic approach, and most of the fluid and the debris inside this thing can be drained by the transmesocolic, I will definitely go for the transmesocolic approach only.
Okay.
Otherwise, if it is projecting
transgastric becomes much better in that way.
Yeah.
Okay. So I think thank you, GV, for sparing that time and excellent discussion. Thank you, Vaiju. We have a fantastic discussion. Thank you, both of you. Thank you, everybody, for joining this evening and making it a very fruitful discussion on the topic. I think next week, same time, again, we'll be meeting here, how magnets can change the surgical life of a surgeon in laparoscopic surgery with Dr. Dominic from Argentina. Okay, thank you very much, Jimmy.
Thank you so much.
Manash.
Yeah.
Thank you, Dr. G.
Thank you so much.
Thank you, Professor Saha. Thank you, everybody, for joining.
Thank you. Thank you very much. Thank you, everybody.
Thank you. Stay safe. Take care. Thank you.
Okay, thank you.
Thank you.
Excellent presentation and discussion. We have enjoyed all the things. Your academic platform is so much mature. Each and every young surgeon should have the advantage by hearing of this academic activity. Dr. Bezu, thank you very much. Dr. Sahoo, thank you very much. And Dr.
Thank you very much.
Thank you. Thanks to all.
Joining. Thank you, everybody.
Thank you. Thank you very much.
Good night.
Bye.
Good night.